Well, now we're going to talk about high blood pressure. High tension refers to the tension of the blood in the arterial system. So high blood pressure. Now I've already seen on this video that blood pressure can vary quite a bit depending on what we're doing. Exercise, for example, will raise blood pressure, and that is normal, that is physiological. But sometimes you get a pathological raising of blood pressure. And hypertension is a sustained abnormal elevation of blood pressure. So it's sustained over a long period of time. And it's very important to know about because high blood pressure can cause quite a lot of diseases, and there's quite a lot that we can do about it to prevent it. So quite an important talk to try and follow. Now, we've said it's high blood pressure, but how high is high? Everyone agrees hypertension is high blood pressure, but how high is high? How are we going to define, indeed can we define hypertension? Well, if you take a youngish adult, a moderate degree of hypertension would be a systolic blood pressure of 140 with a diastolic blood pressure of 90. And it's important, I think, to realise that elevation of the systolic or the diastolic blood pressure constitutes hypertension. Remember, a normal would be something like 120/80. The first figure always refers to the systolic, the second figure to the diastolic. So if every time you took a relatively young person's blood pressure was 140/90, that would probably be moderate hypertension and worth certainly getting a good medical opinion on whether it was worth treating that. Now, definite, everyone would agree that definite hypertension is 160/100, or a systolic over 160, or a diastolic over 100. That would be a definite hypertension. So a little difficult to define. So Professor Jeffrey Rose defined blood pressure as that level of blood pressure above which investigation and treatment do more good than harm, which doesn't help us that much in practical terms. So over 140/90 is a moderate rise, and over 160/100 is a definitive rise. So a blood pressure over 160/100 would definitely require treatment. A blood pressure of 140/90 would require consideration as to whether treatment was appropriate or not. So we've tried to define what we mean by the term hypertension. Let's now go on and look at the possible forms of hypertension that we can come across in clinical practice. Now, the first type I want to talk about is essential hypertension or primary hypertension. This is hypertension which arises, but it's not secondary to any disease process. The person has a primary hypertension. And usually this is idiopathic. We don't know what causes this. So the most common form of hypertension by far is essential or primary hypertension. No apparent cause, no apparent underlying disease of which the hypertension is a symptom. But the next type of hypertension is referred to as secondary hypertension. Now, a secondary condition is a condition which is secondary to something else. So, for example, there might be kidney disease, and the hypertension occurs as a result of the kidney disease. It's secondary to that disease. Now, secondary forms of hypertension are fairly uncommon. Figures vary a little bit, but maybe between 2 and 5% of cases of hypertension are secondary to some other disease process in the United Kingdom and in most of the Western world. So most hypertension is essential or primary, but it can occur secondary to something else. And it's very important that anyone presenting with hypertension, that you should look for these other possible primary causes, because they may be amenable to some form of treatment. Now, another two ways that people sometimes talk about hypertension is benign as opposed to malignant. Now, in benign hypertension, I'm pausing really because it's a bad term. Benign tends to mean innocent and not causing any damage. What it really means, a better term for this would be asymptomatic hypertension, a hypertension which isn't causing any obvious symptoms. Because one of the key things about high blood pressure is in most patients, most of the time, there are no symptoms. There are no symptoms, but all the time the patient is hypertensive, it is doing them damage. The amount of damage that hypertension causes is related to the degree the blood pressure is raised and the amount of time that it is raised for. So in so-called benign hypertension, even although there may be no clinical features at all, no symptoms, the patient realizes nothing is wrong, yet all the time the hypertension can be causing long-term complications. That's why it's so important to screen for it, because someone could be hypertensive, they could be getting organ damage and not realize anything's wrong. So the benign form, asymptomatic. Very often the first time someone knows they have this is when they have some complication of the hypertension, such as a cerebrovascular accident or a myocardial infarction. Malignant hypertension. Well, in malignant hypertension, well, sometimes actually, most times probably, there's a history of benign hypertension, but then for some reason there's a very rapid, severe rise in the blood pressure. So malignant hypertension, there is a rapid, severe rise in the blood pressure. And it becomes life-threatening almost straight away. Now, studies in the United States have shown this is more common in black people living there than white people living there, but it can occur in anyone. A sudden severe rise in blood pressure, almost immediately life-threatening, and would require fairly aggressive treatment. So most times when we're talking about diseases, we spend some time talking about the clinical picture. What are the signs and symptoms of this condition? But the key thing here when we're talking about blood pressure is that for a long time there is no clinical features. The only abnormality you detect is when you actually measure the patient's blood pressure. So often no symptoms. Now, with malignant hypertension, the situation is usually somewhat different because the rise in blood pressure is so extreme. You know, the diastolic blood pressure might be 130 or something like that. The patient becomes incredibly hypertensive quite quickly. Now, what this does is it increases the pressure of the blood in the vessels, and that increases the amount of tissue fluid which is formed at the arterial end of the capillary. And over time it can actually damage the capillaries. And the capillaries it damages are the cerebral capillaries, the capillaries in the brain. So you actually start getting damage to the cerebral capillaries. And that means you get a lot of fluid leaking out of them, so you get the accumulation of fluid under fairly high pressure in the cranial cavity. In other words, you get raised intracranial pressure. So in malignant hypertension, the effects are cerebral edema related effects. So for example, you will get, usually you get nausea and vomiting. Sometimes you get headaches. There may be neurological deficits, and very commonly there are visual disturbances due to the pressure of the raised intracranial pressure pushing the cerebral edema, pushing down on the visual nerves, on the optic nerves as they go along near the bottom of the brain. So remember, benign, usually no clinical features, malignant cerebral edema effects. We're now going to think about the causes, the etiology of hypertension. What is it that causes some people to have this sustained elevation of blood pressure? Well, first of all, let's think about the essential form of hypertension. Remember, that is the primary type. Well, in the primary type, really, we don't know what causes it. We do know that very often there's a family history, so if your parents were hypertensive, you've got an increased probability of becoming hypertensive, but we actually don't know the cause of the essential primary form of the disease. Now remember that the essential primary form was by far the most common, but between 2 to 5% of conditions were secondary to some other disorder. And here there are some clear underlying disorders that can cause it. By far the most common cause of secondary hypertension is hypertension which is secondary to some form of renal disease, perhaps glomerular nephritis, perhaps polycystic kidney disease. So most cases of secondary hypertension are secondary to some form of renal disease. Another possible cause of secondary hypertension is pregnancy. Some drugs can precipitate hypertension. Drugs which contain estrogen, for example, can cause hypertension. There are some cardiovascular disorders which can cause hypertension, such as aortic stenosis, narrowing of the aorta. Hypertension can also occur secondary to disease of the adrenal glands. Remember the adrenal medulla, producing adrenaline and noradrenaline, both of which will increase blood pressure, and the adrenal cortex producing steroid type hormones, corticosterone, which again can increase blood pressure. So the essential primary form, we don't know the cause. The secondary form, several possible causes which can be identified. Now, I've said we don't know the cause of essential hypertension, and that is true. But we do know many factors that can influence blood pressure. So it's very important to advise patients on these lifestyle factors. It can make a huge difference to their blood pressure. So yes, it's true we don't know what actually starts off the high blood pressure to begin with, but it's also true we know about lifestyle factors, we know about advice we can give our patients that will significantly lower their blood pressure. Now, there are some racial differences between blood pressures. If you go around the world with the USFIG and you take blood pressures of all the different races, then you will find variation. And it may be that there is some very minor racial variations in blood pressure. But what is much more likely is the variations in blood pressure you will detect relates to lifestyle factors of those races. So people that are active a lot of the time will tend to have lower blood pressures than people that sit around a lot of the time, like a lot of people in the Western world do. So yes, there are racial differences, but they seem to be related to environmental factors. Indeed, the type of factors we are about to discuss. Now, with increasing age in Western countries, there tends to be an increase in blood pressure. But again, this seems to be related to lifestyle factors. So even people that are getting old, if they are still physically fit and active, often their blood pressures can remain really quite low at young adult levels. So increasing age, there's a tendency, but it may well be related to inactivity and other lifestyle factors. Now, if you eat a lot of salt, that's going to increase the osmolarity of the blood. The blood will become hypertonic, and that's going to tend to attract more water into the circulatory system. That's going to increase the volume of the blood. That will increase venous return, and via the Frank-Starling reflex mechanism in the heart, that will tend to increase cardiac output. That sounds good in theory. In practice, some people are quite salt sensitive and others are not. So a person that is salt sensitive, their blood pressure would tend to rise after taking salt, and a person that is not salt sensitive, well, their blood pressure wouldn't change very much after eating salt. The problem is, of course, when you look at your patient, you can't tell whether they are salt sensitive or not. So we tend to advise all patients to cut down on the amount of salt, the amount of sodium chloride that they eat. Most people eat way more salt than they need because it makes food taste more savoury. What we tend to do is say, don't add salt to your food, and avoid highly processed, very salty foods, because food manufacturers often put an awful lot of sugar, fat and salt into their products. Another lifestyle factor is potassium, and a high potassium diet can actually help to lower blood pressure. So a high potassium diet can actually help to lower blood pressure. So we should advise these patients to eat plenty of fruit and plenty of vegetables. Now there's other reasons for this, but one reason is it will raise the potassium in their blood, and that will help to lower their blood pressure. Fruit and vegetables are a part of any healthy lifestyle anyway. The next lifestyle factor we can discuss is obesity. The fatter someone is, the higher their blood pressure tends to rise. One way to think of this is that there's just more body mass to perfuse. Therefore, the heart has to work harder to get the blood around the larger body. Therefore, the blood pressure has to rise to perfuse the greater tissue bulk. In obesity, what is certainly true is that if patients are obese and hypertensive and they lose weight, then very often their blood pressure will go down as well without additional treatment. So obesity can be quite a major factor. Alcohol is certainly a factor. Alcohol intake and blood pressure are positively correlated. In other words, people that drink a lot have higher blood pressure. Now, this isn't really an acute effect, it's a cumulative effect, but it's still true that the more people drink, the higher their blood pressure will tend to be. So a very important part of health education is to reduce alcohol consumption. A reduction in alcohol consumption can result in a lowering of blood pressure. Now, people often talk about psychological stress. And it's certainly true that short-term stress and anxiety will increase your blood pressure in the short term. That is certainly true. I think it particularly raises the systolic blood pressure actually. But in the longer term, it's more questionable. Psychological stress is probably not actually a major factor in long-term hypertension. Or not that important a factor anyway. Exercise is a very big factor. Exercise helps to lower blood pressure. So if someone is hypertensive and they start taking regular exercise, then that can bring the blood pressure down to quite acceptable levels, very often even in the absence of medication. So regular exercise is a very important factor. And I think we'll just indulge ourselves a little now and try and work out why this might be. Well, if someone's exercising regularly, then certainly they can lose weight, and the weight reduction will tend to lower blood pressure. Exercise seems to reduce the excitability of the sympathetic nervous system. So if there's less sympathetic excitability, the blood pressure will also tend to be lower. Exercise will also increase insulin sensitivity. A certain amount of insulin will have a greater hypoglycemic effect, probably due to the sensitization or the increase in numbers of insulin receptors. And if there's less insulin in the blood, there seems to be less stimulation of the sympathetic nervous system as well. As well as that, if someone takes plenty of exercise and are physically fit, then they can increase the amount of oxygen they're able to absorb from the capillary blood. That means a given volume of blood can carry more oxygen to the tissues. And it is the metabolic demand of the tissue that controls the perfusion of blood through that tissue, the local blood supply. So if a given volume of blood is giving a lot of oxygen to the tissues, as it will in a fit person, then you need a lowered flow of blood through that tissue. If this is true all over the body, then the heart doesn't need to work as hard to generate the blood pressure to perfuse the tissues of the body. That seemed to make sense to me when I said it. These ideas are a little speculative, but what we know for sure is that physical exercise can help to lower raised blood pressure. So ask your patients about these lifestyle factors. Where necessary, get the patient to change their lifestyle, and you can lower their blood pressure and therefore lower all the complications that are associated with hypertension. What I'd like to do now is go on and consider the pathophysiology. What abnormal physiological processes are there associated with hypertension? But just before we do that, I just want to go back to the last point a minute, because it is an important one. Exercise. The exercise we're talking about is aerobic. So it's not quick sprints and it's not doing lots of weights. It's things like walking, cycling, swimming as the patient gets fit, maybe jogging. And exercise, remember, should raise the heart rate, sometimes cause sweating, and ideally last for half an hour a day. So the patient needs to try and build these kind of changes into their lifestyle. Pathophysiology. What is it that's going wrong in hypertension? And now we're considering the essential form of hypertension, primary hypertension. So let's think about the pathophysiology. What is going wrong here? Well, this is a little speculative, in my understanding at least, but there seems to be sympathetic overactivity initially. For some reason, for a period of time, there's overactivity of the sympathetic nervous system. And one of the effects of this is that you get an increased cardiac output. And it is known that early on in the development of essential hypertension, there is an increased cardiac output, even although in the early stages, the peripheral resistance and the peripheral vessels are normal. So we do know there is an increase in cardiac output in the initial stages of the disease. We assume this is due to a sympathetic overactivity. Quite why there's a sympathetic overactivity, I'm not so sure about. But there's an increased cardiac output. Now, if you increase cardiac output over a period of time, in fact, if you increase cardiac output at all, you'll get an increased blood pressure. Blood pressure equals cardiac output times peripheral resistance in the presence of adequate venous return. So you get an increased cardiac output. Therefore, you get an acutely increased blood pressure, if you like. Blood pressure goes up in the short term. Now, over weeks or months, this will result in some vascular changes. So the increased blood pressure will actually start to adversely affect the peripheral blood vessels in ways we'll look at shortly. But the end result of these vascular changes is that you get an increased peripheral resistance. And we know that increased peripheral resistance will increase blood pressure. Now we know that later on in the disease process of essential hypertension, the cardiac output is actually normal, but the peripheral resistance is increased, and we are presuming this is due to vascular changes and damage caused by the increased cardiac output. So the increased peripheral resistance leads to increased blood pressure, and this appears to be a long-term effect. So you get an increased blood pressure over a period of time. And it seems that the baroreceptors must be involved in this as well, because normally if you had an increased blood pressure, you would get an increased number of nerve impulses going from the baroreceptors to inhibit the sympathetic outflow from the vasomotor center, and this does not seem to happen. So the baroreceptors appear to lose their sensitivity to the increase in blood pressure. Now, hypertension accelerates the process of atherosclerosis. In other words, it results in increased rates of deposition of atheroma in the arterial lumens, especially affecting the larger arteries. We've dealt with this in detail on other videos, like number 13 on ischemic heart disease, for example. But for now, let's just remember that the atheroma clogs up the arterial lumen. This has three effects. It causes distal ischemia. The blood turbulence can result in thrombosis and infarction, and the weakening of the arterial wall can lead to aneurysm. So the process of atheroma can lead to any condition caused by ischemia, thrombosis or aneurysm, a very wide spectrum of pathology indeed. So increasing rates of atheroma. Now, if the blood pressure is high for a long period of time, that's pushing on the walls of the blood vessels, of the arterial vessels. And the vessels result in this with a hypertrophy. The cells will grow in size. And in some tissues there may be a hyperplasia as well, a growth in the number of cells. Now this affects the tunica intima, the inside layer, so you get intimal thickening. It also affects the middle layer of the arterial vessels, the tunica media, so you also get medial thickening. Smooth muscle, connective tissues are affected, and hypertrophy. So the hypertension leads on to hypertrophy of arterial walls. These effects are also going to reduce the lumen. Because the vessels are swollen, the lumen of the arterial vessels can become narrowed. In addition to that, the pressure results in the deposition of collagen. Do you remember collagen is a protein? Deposition of collagen, and these get forced into the walls of the vessels. Now collagen is very good for tensile strength. It is remarkably strong, but it is not elastic. It's essentially scar tissue. Scar tissue with fibrous tissue is mostly collagen. So you get deposition of collagen, essentially scar tissue, in the walls of the arterial vessels, causing a loss of elasticity. The vessels become more rigid. The high pressure also forces fibrinogen into the arterial walls. Fibrinogen, you might remember, is a clotting protein. It causes blood clotting because it's converted to fibrin. So the fibrinogen can result in the accumulation of fibrin in the arterial walls, also making them harder and less elastic. These lead on to the disease process of arterial sclerosis, hardening of the arteries. So there's atherosclerosis in hypertension, the formation of atheroma in the arterial lumens. There is also arteriosclerosis, hardening of the arteries. This can lead on to possible even a calcification of the arteries. It can be very, very hard. So the irony here is that you end up with reduced perfusion of the tissues. So even although the blood pressure is high, the tissues end up being hypoperfused because of the disease that the hypertension causes in the arterial vessels. We're now going to think about the complications that are associated with high blood pressure. Now, in a sense, this is the whole purpose of the entire subject, because we want to prevent people suffering the complications that hypertension causes. And the first complication is quite easy to talk about. You get increased morbidity and mortality in hypertension. Now, this graphic looks at diastolic blood pressure and 2-year mortality. So for those with a diastolic blood pressure between 100 and 119, the 2-year mortality rate is 8%. 8% of the patients with this blood pressure will die over a 2-year period. If you increase the diastolic blood pressure to 120 from 120 to 129, just thinking about the diastolic blood pressure, the mortality doubles up to 16%. With diastolic blood pressures of 130 to 139, then the mortality rises to 36%. If the diastolic pressure is over 150, then in a 2-year period, 64% of these patients will die. And in malignant hypertension, where you can get very high blood pressures indeed, well, 88% of patients with malignant hypertension will die within a 2-year period. So high blood pressure, in this case diastolic blood pressure, certainly causes very large increases in mortality. So we're talking about complications here. We've looked at increased mortality, complications associated with hypertension, morbidity and mortality increases. Now, what specific conditions is it these patients are more likely to suffer from? Well, the classic ones are stroke, cerebrovascular accidents, myocardial infarction, cardiac failure and renal failure. All obviously very serious pathologies. So hypertension can contribute to all of these. All of these will be more common in hypertensive patients, depending on how high the blood pressure is for how long a period of time. Some of them can be attributed to atherosclerosis, as we've already discussed. Now, when I was a student, I was taught that diastolic blood pressure was a more important predictor of complications such as stroke, MI, congestive cardiac failure, renal failure, than systolic blood pressure. Well, under the age of 45, diastolic blood pressure is a more accurate predictor of cardiovascular risk, anyway, than systolic blood pressure. So in younger patients, it's probably true that diastolic blood pressure is the more important indicator. In older patients, though, it's probably the other way round. It's probably the systolic blood pressure that is the more important indicator of cardiovascular risk. I think it was the SHEP trial, systolic hypertension in elderly people, demonstrated the importance of the systolic blood pressure as a risk factor or as a risk predictor in older patients. But it's true to say that raised systolic and diastolic blood pressures are both dangerous for the young and the old alike. So it's probably not worth spending too much time working out whether it's the systolic or the diastolic hypertension that matters. Both are important in all ages of people. Now, still thinking about complications, there are synergistic effects in risk factors. Now, what I mean by synergistic effects is something like this. If the cholesterol is 8.6 millimoles a litre, which is high, then the risk of developing coronary heart disease would be 4 times greater. If a person has got hypertension, a systolic blood pressure of 195 millimeters of mercury, their risk of developing coronary heart disease will be 3 times greater. But if someone's got hypertension and hypercholesterolemia, while each risk factor on their own is 4 and 3, if you've got both factors, the risk goes up to times 11. They'd be 11 times more likely to develop coronary heart disease. Again, if someone smokes, then the probability of them developing coronary heart disease is probably 1.5 times greater. But if you smoke with high cholesterol, it becomes 6 times greater risk. If you smoke with hypertension, it becomes 4.5 times greater risk. If you've got all 3 risk factors, then the risk is greatly increased if someone's got high cholesterol, hypertension and smoking. This is why it's particularly important, if someone does have hypertension, that they don't smoke. It's particularly important that their cholesterol is checked and, if necessary, treated, because risk factors of coronary heart disease are synergistic as opposed to additive in nature. Now, we're going to look at the systems that are affected by hypertension individually now, and the first thing I want to look at is the brain cerebrovascular disease. So in cerebrovascular disease, well, there's an increased risk of cerebrovascular disease with hypertension. Now, the first thing here is the blood vessels will become more rigid for the reasons we've looked at. There'll be the hypertrophy of the walls of the blood vessels, the arterial vessels. There'll be the deposition of collagen in the vessel walls. There'll be the deposition of fibrin in the vessel walls. So they'll become more rigid. So vessel walls more rigid as a result of the fibrous tissue in the vessel walls. And this means the normal tissues which make up the vessel walls are partly lost as collagen and fibrin infiltrates the walls. So not surprisingly, the vessel walls will weaken. And an aneurysm, of course, is a weakness in the wall of a blood vessel. So aneurysms can form. There'll be a weakness in the wall, and the blood pressure will tend to blow that out even further. After a certain point, the aneurysm can burst. So there's a high pressure in the vessels. The vessel wall is blown up. The aneurysm can burst, resulting in hemorrhage. And the hemorrhage, of course, is one possible cause of cerebrovascular accident. So hemorrhagic strokes can be caused by hypertension. Now, we've already established that hypertension can lead to atheroma, and atheroma, often affecting the larger blood vessels supplying the brain, is a source of thromboembolic stroke and ischemia. So if there's atheroma in the larger vessels that supply the brain, then the lumen of those vessels will be narrowed and there can be cerebral ischemia. This manifests itself in transient ischemic attacks. And as well as that, the turbulence of the blood over the atheromatous plaques can lead to thrombus formation. That can occlude part of the blood supply to the brain, and in addition to that, emboli can break off the thrombus and go and infarct specific parts of the brain. Now, still thinking about complications of hypertension, we'll go and look at heart disease. Now, because hypertension contributes towards atheroma, you get atherosclerosis in the coronary vessels, the vessels that actually supply the myocardium with its blood supply. In other words, you get coronary heart disease. Now, this can result in ischemia, which can give rise to angina, and it can also cause thrombosis formation, so it can give rise to myocardial infarction. So, heart disease, coronary heart disease, caused by hypertension. Now, as well as that, there's another form of heart disease that can be caused by hypertension. Because the heart is having to work hard to pump the blood out against the increasing pressure,